Good evening, everyone. It's my pleasure to welcome you all to today's webinar on menopause to malignancy. So, speaker for the day is Dr. Pujalakshmi B. So, Dr. Pujalakshmi B is an experienced obstetrician and gynecologist with expertise in women's health, infertility, reproductive medicine, and aesthetic gynecology. She has trained at reputed institutions in India and abroad, including advanced training in reproductive medicine from Germany. With her clinical expertise and compassionate approach towards women's health, we are sure that today's session will be highly informative and valuable for all of us. Over to you, Doctor.
Thank you so much. Thank you, Mediversal. So I'll be sharing my presentation right now. So good evening, everyone. The topic for today is menopause to malignancy. So why I have chosen this topic is menopause we generally feel is the ending of the reproductive phase of a woman, and she's entering into a phase where all her hormones are getting to a closure level, and she's going to have a period free, pain free, and all the other reproductive age related disorders coming to an end, and she's going to settle down with a calm and happy and healthy mindset and body. But unfortunately, menopause also comes up with its own group of disorders, and which is currently on a rise, where we are seeing multiple cancers evolving in and around this age group. We are also generally aware that cancer is a geriatric disease where we see it post 55, 60 years of age, but then a tendency of rise and increase in cancers among women is currently seen to an extent where if we screen around 10 women, around 6 women are found to have either cancerous or precancerous lesions in the current scenario. Can be one of the cancer related to the hormones, can be breast, can be endometrial. But we are seeing a large increase in the number of cancers. So, hence, giving emphasis to this portion is very important clinically, though academically we don't give so much of importance to menopause and postmenopausal bleeding. But the current rise and trend of cancers among menopausal women brings us to a situation where we have to give equal importance as in to things like endometriosis and fibrosis and heavy menstrual bleeding that happens during the reproductive age group. So we'll start with this. So definition by textbook, menopause is defined as the cessation of ovarian function, which results in permanent amenorrhea. So she's going to have a 12-month period of amenorrhea to confirm that menopause has set in, and hence it's a retrospective diagnosis. So only when you take history of when her last menstrual period was, and if it was 12 months ago, and she didn't have any other bleeding episode in the 12-month duration, we can confirm that menopause has been attained. So, as I mentioned, menopause is nothing but the permanent cessation of menses. With increasing age, the woman's follicles are depleted. We all know that in the womb, the female baby is coming out with a good number of follicles, and after attaining puberty, the number of follicles come down as ovulation occurs during each cycle. And while reaching menopause, we are at a dire situation where there are very less or nil number of follicles, which is in turn creating this cessation of menstruation. So in the worldwide scenario, the average age is 51, whereas the menopausal age in Indian women is around 47, which is an average age. There can be plus or minus. If until 55 she hasn't attained menopause, it is considered as late menopause. So there's another alarming thing that is happening called early menopause, where women as young as 40 years undergo cessation of menstruation, and this term is called as premature menopause, or more likely to be called as premature ovarian insufficiency, where she will not be able to ovulate and produce a good follicle for reproduction. And there might be depletion of the follicles also from the ovary as young as 40 years of age itself. So early menopause can be associated only with two main things. Either it comes in the family, genetic predisposition is there, or there is a history of smoking with the women. So we can't really put premature menopause as a hormonal issue or something related to the HPO axis, but it is purely dependent on two factors. One is genetic predisposition and other is smoking. So, as I mentioned, the age of menopause, if in case it is an early menopause, it is not related to the age of menarche. That if they had earlier menarche or later menarche, it is not related to that. It is not related to the number of children, the parity. It is not related to, as I mentioned, the hormonal,
Yeah.
internal hormonal
Do one
cycle,
thing.
or
You only come directly from Kashmir. We'll book a flight instead of her and give interview and go.
sorry. So, the oral contraceptive usage, which is external hormonal usage, or the socioeconomic status, where certain diseases are prevalent in the high socioeconomic status or in the low socioeconomic status, whereas this is not related to that, or the race. So we just saw that approximately the Indian average is 47 and worldwide is 51, which is not much of a difference. So interracially also there is not much of a difference at the age of the menopause. So, what is the menopausal transition that is happening in a woman when she reaches 47, 48 years of age, when she has like one or two grown up children, and her cycles are beginning to become erratic, irregular, and what really happens to move to this menopausal phase is that she is moving from her reproductive phase, which is solely between 21 to 45 years of age, to the postmenopausal life. So this transition period happens between this 47 to 52, 53 years of age. And then after 55, she enters that postmenopausal period, which it itself is a different scenario, challenging scenario for the woman to face physically and mentally. So 10% of the women might have abrupt stoppage of menses, which is a very small percentage. The remaining women will not have abrupt stoppage of menses. They will have several uh, clues and several symptoms pertaining to menopause, which will lead to a slow transition into the menopause, and thereby, after 12 months, realizing that she has actually attained menopause. So, what is the pathophysiology behind this? So, as I mentioned, the hormones are going to come into a lower average. So, the androgen production, females also have a percentage of androgens in them and estrogen and progesterone. So, there is 50% reduction in androgen production and 66% reduction in estrogen production at menopause. So, prior to this phase of starting of menstruation, premenopausal cycles become anovulatory. So the number of follicles are getting depleted. So the ovary it itself tends to not produce a. So what happens because of this? There is irregular ovulation or ovulation failure that happens. So corpus luteum does not get produced in the ovaries. So generally, what happens during ovulation? The FSH-LH act upon the ovary. The follicle is formed. The dominant follicle gets released. After the release, there is corpus luteal formation, and the corpus luteum helps in the production of progesterone. So, in this, the FSH-LH getting into the ovary and then not able to produce a Graafian follicle, not producing a dominant follicle, hence thereby no ovulation and no corpus luteum formation and no progesterone. Naturally, the progesterone level starts to decrease. So this is how slowly the female hormones are shutting down in the menopausal phase. So later, the Graafian follicles fail to develop, and estrogenic activity naturally decreases because of this, because there is no rise in peak of hormones. And because of this, the action on the uterus is also reduced. So, ovarian production of hormones and action on the uterus is reduced, thereby, the endometrium, which forms and shreds every month, that is also going to be atrophied right now, and slowly it is going to lead to amenorrhea, where there's no shredding of endometrium because lack of estrogen, lack of progesterone, there's no shredding, and slowly it is going to lead to amenorrhea. So the cessation of ovarian activity and the fall in estrogen causes a rebound increase. So what does the HPO axis think? There is not enough estrogen. Let me keep on stimulating the pituitary. So pituitary will end up producing more than necessary amount of FSH and LH. There is feedback mechanism that is happening because the ovarian production of estrogen progesterone is naturally becoming less. The pituitary thinks it is not enough for the body to function, and naturally it kind of keeps on increasing the FSH and LH to an extent where even that FSH and LH is not giving any positive impact in the ovary and increasing the female sex hormones. So finally, what happens? There is low levels of estrogen and progesterone, low levels of androgens, and high levels of pituitary hormones, FSH and LH. So the average values of E2 remain as low as 5 to 25 picogram per ml. FSH becomes as great as 40 international units per ml, LH around 50 to 100, and androgen around zero point 0.3 to 1.0 nanogram per ml. So, if at all a woman is coming to your OPD with a doubtful scenario, maybe average of 53-year-old lady who's coming with, she's saying, I'm having cycles once in 15 days and then suddenly once in 3 months, there is no connection between the last menstrual period and this. I'm having some hot flushes, I'm having irritability, mood swings, and the last 6 months I've been having an erratic cycle. So to clinically come to a conclusion, which hormone will we be testing? Can anybody give an answer to that in the comment box? Can anybody give me an answer? So this is the scenario. Woman is walking into you with erratic cycles for the last 6 months, and she's having no connection between the previous LMP and now. And then she wants you to check what is going on with her. And the first thing you think is, oh, she must be premenopausal. So, which hormone do you think can clinically be evaluated to give us an idea? Anybody? Very good. Zara, FSH and LH will give us a clear picture what is going on with the lady. Very good. So as high as 40. So premenopausal, if you see something like 38, 35, we can have a very clear picture that she's undergoing premenopause and she's going to attain menopause very soon, and we can reassure her that nothing is wrong with her, and this is a natural way of her hormones and ovaries shutting down. So, what are the early features that we can see in menopause? In the pre and perimenopausal time, the things that the women come to us in the OPD saying, I can't take this, mainly is the psychological symptoms. They have too much of irritability. They like shout upon people who are uh, dear and near to them, and saying, I don't know why my anger and emotions are not under my control. They undergo a lot of depressive episodes, insomnia, fatigue, and lack of concentration and loss of memory. So physically, when we see, they might get these hot flashes where suddenly they develop some hot sensation, and sweating and palpitations happen, and they might not really have a particular reason why this is happening, and they are going to have a lot of insomnia, and because of not sleeping well, the psychological issues might tend to flare up even more. And generally, as the reproductive health is going down there, and the hormones are going down, they might have decreased libido and painful intercourse. This is dyspareunia. And since the laxity of the muscles around the bladder also are undergoing changes, there can be things like urinary stress, incontinence, recurrent UTIs, all these things happening in the early phase. So here you can see an image of a woman undergoing menopause, and the various features that we can depict under each region. So, brain fog, something psychological, and along with depression, anxiety, and insomnia, headache, migraines, hot flushes, night sweats, irregular cycles, vaginal dryness, frequent UTIs, heart palpitations, shortness of breath. The skin changes. The skin is not as uh, moisturized, or as it can retain moisture. It becomes very dry and itchy in all parts of the body, including the vagina and the urinary regions. Decreased libido, mood swings, and loss of bladder control and dyspareunia are some of the features that we see early time of menopause, which gives us a clue that okay, she is undergoing all these changes. So it might happen in a few months time. So this is in general, we saw these symptoms that are happening, but in particular to the menstruation, what are the changes that occurs? So there is sudden cessation of menses only in 10% of the females. So that is not the case with the remaining 90%. Suddenly one day stopping and then 12 months no periods happens to very few women, and they're very lucky that they do not have to face all this pre and perimenopausal symptoms. They might have those symptoms postmenopausally, but there is gradual diminution in the amount of blood loss with each regular period until the menstruation stop. That is the main type of change or scenario which is common among menopausal women. Gradually, the amount of blood loss decreases, and then with each period, once in a case, if there is 5 days of menstruation, it becomes 3, it becomes 2, and it becomes 1, and then it stops. That kind of blood loss is what we are looking at in general, and there is gradual increase in the interval between periods. So that I had mentioned earlier, a woman walks in and she says, I had one period, uh, like within a month I had 2 periods, and then there was no periods for 3 months. So that kind of intervals that are not predictable for one year of period is another menstrual symptom that we can note. So one among these three happens with pertaining to the menstruation. So there are some late symptoms of menopause pertaining to after a cessation of periods, and then the prolonged effects that lack of hormone deficiency that gives rise to this late menopausal symptoms. So menopause, women with chronic estrogen deficiency, that is 1 year of cessation of periods, so there is no internal estrogen production. So this will lead to uh, things which were dependent on the estrogen to thrive, like the bones and the heart, which was being protected because of the estrogen that was internally secreted. So they might develop arthritis, osteoporosis, fractures easily at this stage, and cardiovascular accidents like ischemic heart disease, MI, and atherosclerosis and hypertension. Stroke also is quite common because they have a tendency to develop chronic diseases like hypertension, hypothyroidism, and diabetes, Alzheimer's disease, anocolonic cancers, prolapse of the genital tract, stress incontinence, and pertaining to the eye, cataract, glaucoma, and macular degeneration. So, as we generally advise to patients, when somebody undergoes a menopause, it is not like, okay, her periods are over, let her take rest and uh, do good with that. No, we also have to screen them, have a health checkup once a year or twice a year to see the condition of the body post menopause. What are all the changes overall happening? Is there something drastically happening, so that we prevent such morbid illnesses from happening? That is the point we get to see from these symptoms. So I was telling something about perimenopause. So perimenopause is like a flag that is been waving itself for a long period, saying it is arriving, it is arriving, it is coming soon. So be ready and be prepared for this. So this is variable between 2 to 8 years, average of 5 years. So this is the period of transition from pre to menopausal period. So the menstrual irregularities could have been there for 5 years also, gone unnoticed. If it was earlier, like in 45, 46 years of age group, and they were just worried because medically they may not be aware that 47 is an age of menopause. They might think it is 50 plus, 55 plus, and they might have even taken hormonal supplements to get withdrawal bleeding. So all those history to note the irregularity of the cycles, the duration, the blood flow, the decrease in number of days, the number of amount of blood loss, the number of pads used, all this history is very, very important to give a clue to the woman, at least expect in a few months or a few years that you're going to attain menopause. So it can have shorter or delayed cycles. Only after a period of 1 year of amenorrhea, the woman enters menopause. So, is there a big help from the physician or the gynecological side to help the women undergoing menopause? Yes, we can be of great help. And as earlier, we never used to take menopause very seriously. It is just a phase. They might have these small symptoms, they just have to live with it kind of idea has changed both in the patient front and the doctor front. And doctors are very much now involved in counseling and helping the patients undergo this transition very beautifully. So counseling is utmost important to help them um, take the right supplementation. Okay, are we transitioning to a phase of osteoporosis? A calcium and vitamin D3 supplementation is going to be of great help in preventing fractures, and if any history of falls from getting into something major. And if they're having some difficulty in sleeping, insomnia, anxiety, and depression, mild tranquilizers will help them restore their sleep cycle and in turn have a better presence during the day. And hormone replacement therapy is definitely of great use if the symptoms are not of her control. If she is unable to bear the symptoms and it is affecting her day to day activities, is an excellent option to give about 3 to 6 months, weighing the benefits outweigh the risks, meaning we are going to categorize them into people who will benefit more than get risks out of estrogen or progesterone. So, somebody with already a coronary artery disease or a ischemic heart disease, we are not going to put them under hormone replacement. But then there is somebody who is mm, or borderline hypertensive. We can see whether if she sleeps better and if her hormones are going to give her a better scenario and even lower her anxiety and everything, if that is going to give her more benefit, we will take that risk of giving her hormone replacement, but not in a scenario where it is already a ischemic heart disease, frankly, and then we add upon estrogen. That kind of scenario, this is not of any use. So, at the end of 3 to 6 months, they are usually symptomatically better and they do not probably require further hormone replacement. So, moving on to the next topic. So, we just saw the various issues that happens during menopause, but there is one pricking issue that happens to this age group of women, and is coming out of the blue to them one day, and they really don't know what to do about it, or generally they tend to ignore it as well. So 12 months of amenorrhea, and then suddenly there is some bleeding into the genital tract. So that is what is called as postmenopausal bleeding. So bleeding from or into the genital tract after 12 months or more duration of amenorrhea. It could be one single episode, isolated episode, or could be multiple. So the most common cause in our country is cervical cancer. We are still a HPV prone country, but there are other causes as well, which is where we are heading to towards today. The most common uterine cause is senile atrophic endometritis and can also be endometrial hyperplasia and endometrial cancers, which were a result of hormone replacement therapy containing tamoxifen or estrogen. So I told you that estrogen is also we use it only when the risk outweighs the benefit outweighs the risk, and tamoxifen is one SERM, selective estrogen receptor modulator, which is generally used for um, preventing the recurrence of breast cancer. So it is taken for a longer duration of time, like 5 to 10 years period, which in turn has the very basic side effect of increasing the endometrial thickness and giving rise to a second cancer, which is endometrial cancer. So nowadays, the use of tamoxifen is also coming down because of the rising number of endometrial cancer cases, and estrogen producing ovarian tumors are also going to indirectly increase the endometrial thickness and lead to a bout of bleeding. So, when you see a postmenopausal lady coming to you with a single episode of bleeding, the history that we take first is what was the age of menopause that she had, whether it was early, late, or it was the right age of menopause. And if there was any history of taking estrogen hormone replacement or tamoxifen for one of the breast cancers she had had earlier, and if there was any history of abdominal pain, any foul smelling discharge, and if it is associated with any other urinary symptoms such as incontinence, recurrent UTIs, or rectal symptoms. So, as usual, we examine her in general blood pressure, general examination, noting the BMI, doing an abdominal palpation with a speculum examination and bimanual pelvic examination. So, we have taken the history, we have done the examination, we have done the per speculum and per vaginal examination. By this time, the gynecologist should have elicited where from the bleeding can be. It can either be a simple vulval erosion to vaginal outgrowth, it can be a cervical cancer, or it can be endometrial hyperplasia. We need to come to a conclusion. Probably this is the region where the bleeding is coming from. So, if at all it is a very visible growth on the cervix, we will do a punch biopsy at the section. It is very simple. When we do a per speculum examination, we note a growth on the cervix. To do a punch biopsy just takes another 5 minutes, and clear picture of the disease will come from the histopathological report of the punch biopsy. So, along with the punch biopsy, it is recommended, if we feel the outgrowth is looking suspicious, to do a pap smear and a HPV DNA testing at the same moment. Our whole evaluation clinically is completed almost by this three tests. And in case you feel externally by per speculum and doing a bimanual pelvic examination, there is nothing wrong with the vulva, vagina, and the cervix, and your suspicion is towards the endometrium, then we do a transvaginal ultrasound, which is going to give us a very clear picture of the endometrial thickness, the inner uterine lining, if there is a thickness. Then we are able to measure the thickness also and act according to the thickness. So if it is of uh, less than 4 millimeter, then we do not have to worry much, because we expect thickness of less than 4 in a postmenopausal woman. But then still she had a previous bleeding episode, so it is not advisable to just evaluate the thickness and just see if it is 4 and just leave it as like that. We can just reconfirm it with the CT and MRI pelvis. So if there is a thickness of more than 4 it is alarming to us, because she has a postmenopausal bleed and she has a thickness of more than 4 in the postmenopausal age group, which indicates clearly there is something going wrong with the endometrium. So instead of waiting and looking at bigger imaging, we can as well go for a office biopsy, that is an endometrial aspiration biopsy in the OPD itself, where we take a part of the endometrium, send it for histopathology, and we'll very much come to know what the pathology behind it is. If at all that is not it is giving a conclusive evidence, the next gold standard method of evaluating any endometrial pathology is doing a hysteroscopy and doing an endometrial biopsy while doing the hysteroscopy, which gives a reconfirmation of the existing pathology that we had detected through the endometrial aspirate. So, the endometrial aspiration office biopsy will give us a preliminary diagnosis when that biopsy is sent for histopathology. That can be reconfirmed along with the hysteroscopy and a endometrial biopsy during the hysteroscopy, and a secondary reconfirmation is attained through that method, which is the gold standard method of evaluation. So, so we have done so much. We have, for example, we are having a woman who is done ultrasound transvaginal, having a 7 thickness of endometrium. So we do office biopsy and a hysteroscopy. If it is less than 4 we undergo a MRI or a CT. for the women to see if there is nothing that we are missing out. If it is a cervical cause, we are doing a biopsy, we are doing a HPV DNA, we're doing a pap smear, and all this is proceeded only based on the histopathology. So, if at all we come to a conclusion that this can be medically managed, then we take upon tranexamic acid and see if the episodes do not repeat, keeping in mind the pathology is not something that can be neglected. So after this, the next region that we can go to is the uh, bladder and the rectum to see if the origin of the bleeding is from the bladder or the rectum by doing a cystoscopy or a proctoscopy. So we can try medical management, which is a temporary solution, because postmenopausal bleeding, medical management is still not okay for the physician or the gynecologist to do, because any day the pathology can change. So, and if she is still symptomatic even after giving her tranexamic acid and trying to control the bleed, if there is persistent postmenopausal bleeding, then the only choice that we have is doing a hysterectomy, and then the entire sample undergoes histopathology to confirm why it has been an uncontrolled postmenopausal bleeding. If otherwise she doesn't have something that is of alarming uh, causes and it is controlled by medical management, we can wait for the hysterectomy. But then, if there is a scenario where there is uncontrolled bleeding, multiple episodes of bleeding, and we do know there is a biopsy proven pathology, for example, endometrial hyperplasia, then it is better to do a hysterectomy rather than letting the women suffer. So, this moves on to the next topic, which is endometrial cancer, which is one of the most common reasons for postmenopausal bleeding in the current scenario. So, the risk factors behind endometrial cancer are early menarche and late menopause. So, this is why we had to derive our topic from menopause. What happens with early menarche? The HPO axis is activated early, and late menopause, she is having an active HPO axis for a longer time. So the entire number of years to which she was getting unopposed estrogen and progesterone to her endometrium was longer than normal. So that much of estrogen is enough to produce such a cancer. And nulliparity, where there is no break in the HPO axis. Obesity, again, unopposed estrogen. Tamoxifen, as I mentioned earlier, which is used for other cancers as a drug to prevent recurrence, in turn gives rise to endometrial cancer. And increasing age, it is a geriatric cancer which is seen mostly after 55 to 60 years of age. So there must be some factors that are protective against endometrial cancer. Otherwise, the risk factors are quite common. We see a lot of obesity, we see a lot of early menarche and all happening, but there are certain protective factors which prevent endometrial cancer from happening. Multiparity, where there is multiple breaks in the hormonal cycle inside the body. Oral contraceptive, where the internal HPO axis is suppressed and external estrogen progesterone is taken. So there is break again in the internal estrogen from acting in the endometrium. Smoking is surprisingly a protective factor from endometrial cancer, but we are also aware that smoking is a causative factor for many other cancers. So really not a protective factor against all cancers. So, and the average age, as I mentioned, is above 55 years up to 70 years of age. And the most common presentation is irregular vaginal bleeding, and the most specific presentation is postmenopausal bleeding. So 12 months she has never had periods, and then suddenly there is a bout of bleeding, and you try to treat her with uh, for example, it is a 54-year-old woman. She has had a 6-month period of amenorrhea, and then she has had a bout of bleeding. You just give her some medical management. You just control the bleeding, and then she goes home happily, comes back to you after 2 months saying, for 1 whole month I had bleeding, and I tried some home remedies, nothing was happening. It is just going on bleeding. You try all sorts of medical management, nothing is happening. Then it should strike you that we have to evaluate her immediately for some pathology related to the endometrium. Could be endometrial hyperplasia or even endometrial carcinoma. So pain is generally a late feature. So the heavy menstrual bleeding, or prolonged bleeding, or erratic, irregular bleeding, or a single bout of bleeding after a period of amenorrhea is the common feature. Pain is not really a common feature. It is in the later stages, when it is going on and on, that pain actually develops because of uterine contractions. And there is referred pain seen in the hypogastrium, which is termed as Simpson's pain. As I mentioned, during the postmenopausal bleeding episodes investigations, where you do a per speculum examination, you do a bimanual pelvic examination, you see there are no changes in the vulva, vagina, or the cervix. Usually, that is the same scenario when we deal with an endometrial cancer. During the physical exam, nothing is wrong except that she's had a bout of bleeding. Maybe she's having some hypogastric pain, often leading us to do an abdomen and pelvic ultrasound. And most common route of spread is direct extension. So directly, uh, it is going to spread to the cervix and the vagina and the ovaries and the fallopian tubes or the parametrium. It is not of lymphatic or blood spread, it is direct extension. So it is quite a fast disease, fast growing cancer. So, as I mentioned, the preliminary investigation that we do is an endometrial sampling of his biopsy. When we have a suspicion and when the endometrial thickness is more than 4 we do not ignore that. We just do a endometrial sampling aspiration biopsy at the same consultation itself. So we have done the endometrial sampling biopsy. We have sent it for histopathology. So the pathologist will give us a interpretation, HPE report, which will again determine how we are going to move about with the disease. And it is also a document with which, after we treat the cancer, we reconfirm the diagnosis with the histopathology of the specimen that has been sent after surgery. So this is acting as a primary document which we reconfirm with the surgical specimen as well. So there are two types of histology that we notice in endometrial cancers, type 1 and type 2. Type 1 is the most common histology. 80% of the histology is of this type, which is a endometrioid adenocarcinoma. This is of good prognosis, and um, it occurs because of unopposed estrogen in mostly people with chronic illness like diabetes and who have been obese. And it occurs generally in the earlier menopausal age group, like 55 to 65 years of age. And this is of a good prognosis because this is going to respond well to the treatment, the medical management, and the further treatment and the surgical management that we do. This has a better response than the second type. So this is estrogen responsive and it is associated with endometrial hyperplasia. And the two important mutations which it is associated with is P10 mutation and KRAS mutation. The type 2 histology is serous clear cell carcinoma, which is coming from the atrophied endometrium. This scenario is totally different from the type 1 histology, which is more common: obese women, diabetic women, early 55 to 65 age group, unopposed estrogen, could have taken oral contraceptives, would have been on tamoxifen therapy. All those typical scenarios fall towards the type 1 histology. But this is a senile woman, a thin physique woman, who's in the later age of menopause, 65 to 75, probably had her menopause 10-15 years back, and estrogen has nothing to help around in here, and it is from an atrophic endometrium, which is even more difficult. When I said, when we do an ultrasound, if there is a less than 4 we generally don't ignore the women, we send her for CT or MRI, which can pick up this. So that is why it is very important. From atrophic endometrium also, we are going to get another type of cancer, which is serous clear cell cancer, which is not going to give us much clues in the um, clinical setup. But then we should be very careful about this. And the precursor of this is serous endometrial intraepithelial cancer, carcinoma, and it is driven by this TP53 suppressor mutation, which gives a abnormal P53 gene, and also associated with HER2 and P16 overexpression, whereas that was a P10 and a KRAS mutation that was associated with the type 1 histology. So, based on the molecular analysis, also we will know whether this endometrial tumor is something which is going to give us a good output or not. Usually, the type 1 histology is the one that responds well to surgical management, chemo, radiation, other immunotherapies, medical management, etc. The type 1 histology gives us great prognosis. But type 2 histology is generally a tougher scenario, and it is also older women where we can't be very aggressive about the treatment, but still the prognosis is also poor. So it is a very difficult and complex situation where we have to weigh our options and see which she will adapt to better. So molecularly analyzing the tumor also is going to give us uh, whether which mode of treatment or which modality of treatment will be of great use to this uh, cancer. So pole mutation is something called polymerase epsilon gene, so which immediately gives us a thumbs up that we can treat this well, and it has a good prognosis and we can actually treat aggressively. When there is microsatellite instability, MSI is another type of gene, and if there is no specific molecular profile, also is an intermediate prognosis where we weigh our options whether we only do surgery or we do chemo radiation along with that, or we do only chemo radiation based on the age. It gives us a weighing of options. Poor prognosis, where we know already the situation is bad, aggressively treating the patient is also not advisable when there is a poor prognosis, and better to discuss the options among all these when we are going ahead doing an office biopsy, we're doing a CT/MRI, we're doing an ultrasound, we are sending for histopathology, and then we say we'll do a molecular analysis. The patient and the whole family is going to be in a crisis situation, like what is going on, what will be the outcomes. But this molecular analysis will give us a clear picture what is going on, whether it is treatable aggressively or we do a conservative treatment. All this clear picture for both the clinician and the patient side, uh, this is of a very useful tool. So as I mentioned, IHC is done for HP from initial sample or from the hysterectomy specimen to stratify the risk and tailor adjuvant therapy. So when we do the endometrial sampling biopsy itself, the immunohistochemistry is done in the same biopsy sample. The pathology is also mentioned, the immunohistochemistry is also mentioned. And then, mostly in the case of endometrial cancer, where the patient undergoes a hysterectomy in 95% of the cases, the specimen sample of the surgery, the uterine sample with the adjunct structures, is again undergoing histopathology with immunohistochemistry, so that we can match the samples and stratify the risk analysis with the molecular markers and tailor make a treatment for each patient. It is not like other diseases where there is a fixed management scenario and one fixed scenario works for all the patients. It is tailor made for each patient based on the initial HPE and IHC and the final HPE and IHC. So the very important staging based on which we act upon the endometrial cancer, which is important if you're in your UG, if you're preparing for your NEET, if you're in your post graduation, if you're in clinical practice, everything depends upon the staging. So the staging is classified into early and advanced staging. So there is stage 1 to 4. So each has various subdivisions. So the one is there where it is very much confined within the uterus, and 2 is where it is going into the cervix, uh, 3 where the adnexa and the vagina and parametrium and lymph nodes get involved, and 4 is a metastatic disease where the adjunct structures like bladder and rectum and distant mets are seen in other organs as well, and distant lymph nodal metastasis occur. So that is 2023 FIGO staging is very important, which uh, each stage can be tested and asked, and uh, the MCQ choices can differ based on each stage. So in endometrial cancer, till 1B, I can say, till 1B is a safer scenario, and we can assure and reassure the patient that it is a much a curable disease, because it is not like older days where once cancer is diagnosed, we are helpless from the clinicians, and we do give a reassurance to patients where we see 1 to 1B stages, that it is a curable disease. Patient can live cancer free after treatment, and that is where staging plays a very important role. And this staging also dependent on certain factors, like preliminarily what we have assessed, and after surgery reconfirming each and every specimen that has been sent for histopathology. For example, if we have sent the uterus along with the pelvic lymph nodes, if the cancer is present only within the endometrium, if it has invaded the myometrium, if it has reached the stroma, if it has pierced itself to the parametrium, if it has spread through to the pelvic lymph nodes, if it has gone to the para-aortic lymph nodes, if it has gone down into the cervix, if it is invading into the vagina, all these things can be reconfirmed only by a surgery. So it is a surgical staging rather than a clinical staging. Though we can do a MRI CT, we can do a positron emission tomographic CT to see where all the spread is and give a particular dimension to the tumor. The final conclusion of the stage is only surgical. So 95% of the cases are surgical evaluated and given staging. The remaining 5% are metastatic diseases where surgery is generally not recommended because the disease is already spread to multiple organs, and only removing the primary tumor at that stage is not going to give us of much use or help us give a staging. So that is why I keep mentioning that the final disease is only with the surgical specimen that we take out of the cancer. So, stage 1 is confined to the body of the uterus. It is non aggressive histology, that is type 1, no focal spread, and 1A is confined to the myometrium alone, less than 50% of the myometrium. 1B involves more than 50% of the myometrium. 1C is aggressive histology and confined to the endometrium. So at this stage, we can still give a reassurance that patient can come out cancer free. Stage 2 is where cervical stroma is involved. So it is crossed all the layers of the uterus and has reached the cervical stroma. It is non-aggressive histology, and aggressive histology with any myometrial involvement comes under stage 2. And stage 3 is where there is breach in the uterine serosa and the adnexa. So 3A, this is where it becomes complex, where it is breaching the serosa and the adnexa, meaning the peritoneal spillage can happen at this stage, and easy spread of the disease can happen. So vagina and parametrium below the pelvic and peritoneum can be involved in 3B. And if pelvic and para-aortic lymph nodes are involved, then it is 3C. So, stage 4, as I mentioned, is distant metastasis, which is involving either bowel or bladder, could be uh, distant metastasis to other organs like lung or any other distant organ, which is in close proximity or distant proximity. And the inguinal lymph nodal spread is also seen. So, here you can see a image of endometrial cancer uterus, a gross specimen, which you see, which is a round globular in shape, rather than the small triangular shape of the typical normal uterine shape and size. This is globular in shape and enlarged in size. So this is a cut section where you can appreciate the endometrium being grossly thickened and like a outgrowing aggressively, and you can see the lower edges which are still having the bloodshed. And this is something where myometrium is maybe 50% involved, is still not piercing the uterine serosa. So what is the management of endometrial cancer? So when it is clinically confined to the uterus, that is stage 1, where I was telling you it is still within the uterus, within the myometrium, it is not piercing the serosa, it is only the uterus. Surgical staging is done only when we do the surgery, and in this we do a extrafacial hysterectomy with bilateral salpingo-oophorectomy, pelvic and para-aortic lymphadenectomy, meaning we dissect only the uterus and the cervix and the fallopian tubes and ovaries. We are not taking out the parametrium, we are not invading into the adnexa, that is extrafacial hysterectomy. But in case cervix is completely involved and then it is going into the vagina, then radical hysterectomy, where we do a dissection and take out the parametrium, adjunct structures, the fascias, the all the ligaments, everything together to achieve tumor free margin. So to an extent where we know there is nothing cancerous that is left behind, that is done for all the remaining stages where we are not sure that it is only confined to the uterus. And in the advanced stages, that is 3A, 3B, 3Z, debulking surgery and post-op chemo radiation is generally advised. Nowadays, it is also dependent upon the surgical staging, where we detect if the lymph nodal spread is present. Then again, chemo radiation plays a role, because if the spread has occurred to a lymph node, meaning adjunct structures can also be involved, and we do not want a recurrence to happen, in which chemo radiation gives us a hand and prevents recurrence from occurring. So post-op radiation is compulsorily given to type 2 histology, which is a very aggressive, poor prognostic disease, and stage 3 or 4. And if there is a grade 3 invasion and myometrial invasion. In case of stage 1A, generally we do not do chemoradiation, only surgical management is advised. And lymph nodal dissection is probably done from stage 1B onwards, but we can omit lymph nodal dissection only if the tumor size is less than 2 centimeters, less than 50% myometrium is involved, or no enlarged nodules or extrauterine disease. There is a confinement of the tumor to very small in size. If myometrium is not involved, no nodes and no invasion outside the uterus, then we do not have to do lymph nodal dissection. But compulsorily, after the size is more than 3 centimeters, we generally start dissecting out the lymph nodes. So this is a case which I had operated on, I think, a few months back. So let me briefly give the history, which is a very interesting turn of events. So 1 year back, she had a fall in her bathroom, and she had a fracture of her femur bone. So she was undergoing the internal fixation and plating of the femur, for which she was on treatment with her orthopedician and undergone surgery. And incidentally, she had to undergo an MRI to see the position of the plating, which is done for her femur fracture. And incidentally, in the MRI, they have taken a pelvic picture also, for which the reporting was done. And the orthopedician had noted that her endometrial thickness was well beyond normal, around 17 mm, if I'm not wrong. And then immediately she had been referred to us, saying that she needs to be evaluated for the thickened endometrium. And at that moment, she had mentioned to the orthopedician that she has had 6 months of continuous bleeding, though she had had menopause like t- 12 years back. So, this is the case scenario she has come to us with. And we had to do endometrial sampling biopsy, which confirms the presence of endometrial carcinoma. And clinically also, um, the perfect scenario of uh, uncontrolled bleeding, which was not being controlled under medical management too. She had taken on and off some uh, remedies by herself, and it didn't stop the bleeding, and she was having continuous bleeding. And to our surprise, uh, it had it is so much such an aggressive type of histology that the lymph node also was involved. Unfortunately, she is already on wheelchair because of her femur fracture, but she had to undergo radical hysterectomy. And you can see the cover that is beside has the pelvic lymph nodal dissection. and the tumor has already spread to the level 1 of pelvic lymph nodes. So she has been post-op. She has recovered well from the surgery, but she has to again undergo chemoradiation because the lymph nodal spread is present. And you should note that, see, when such a lady at 62 years, she's been having so many bouts of bleeding and no care has been given for that. So how important it is to evaluate such a woman, and some incidental finding has actually saved her life today. So that is the lesson learned from this entire scenario. And she's again, 3 cycles chemotherapy has been completed and she's doing fine now. So that concludes the topic for today. Thank you.
So if you have any questions, please drop it on the chat box. Doctor, I think we can end our session.
Okay, fine.
Okay. Thank you, Doctor, for this wonderful session. And for participants, I'll be sending out the feedback form. Once you fill the feedback form, automatically the certificate will be sent to your mail. Thank you. Thank you, Doctor.
Thank you so much.